Hello and welcome everyone. It's just 1 minute past 12, so we will get started and thank you for joining our 6th CfSD National Clinical Pathways webinar. My name is Stuart Sutton. I am a GP in Renfrewshire and here as clinical lead for primary care, secondary care interface with CfSD. So these webinars are designed to showcase some of the pathways developed by CfSD in collaboration with clinical communities and to provide a forum for education, informal discussion and Q&A. This particular webinar relates to the full clinical review of the Scottish Referral Guidelines for Suspected Cancer, and it's great to see we've got such high attendance for this session. In terms of some housekeeping, so we would ask that colleagues, when you have the opportunity to ask questions, this will be through the Q&A box at the top there, so it's next to the chat function. Much easier if you could put your questions in there as we go through, and then at the end we'll have a Q&A session and they'll be directed to the relevant speaker. There will be opportunity to raise hands at the end, but if possible, if you could use the Q&A function during the talks, it'll be less distracting. We've got quite a packed agenda to get through, so that would be helpful. I'm going to take the opportunity now to hand over to Lorna Porteous, who is the co-clinical chair of the Scottish Primary Care Cancer Group. Over to yourself, Lorna.
Thanks, Stuart. Hello, everybody. My name is Lorna Porteous. I'm the GP lead for Cancer and Palliative Care in NHS Lothian, as well as Stuart mentioned, the joint clinical lead of the Scottish Primary Care Cancer Group. And I was also the vice chair of this review of the Scottish Referral Guidelines. So the Scottish Referral Guidelines were first published in 2002 and have had various revisions over the years. And as Stuart mentioned, this most recent review was a full clinical review. The guidelines are designed to identify cancers at an early stage where possible, as well as supporting appropriateness of referral. So it's essential that all clinicians, including those making and receiving referrals, are working from the same guidance. We're all working to achieve the same thing: earlier detection and better outcomes. Today, we're going to hear about the project review process, the key changes that have been made, and the implementation and next steps. There will be time at the end for questions and answers, so as already mentioned, please do put your questions in the Q&A section as we go along. I'll now hand over to Sarah Wink to talk about the project process.
Thanks very much, Lorna. So, hello everyone, I'm Sarah Wink and I'm the project manager of the SRG review, and I'm just going to go through the process we followed during the review. So this image shows the review process as a whole, starting with the scope and plan, where we undertook a stakeholder survey to canvass for evidence and data to be considered, and we commissioned the collation of evidence and data from Healthcare Improvement Scotland and Cancer Research UK. And then leading into the engagement and consensus period, where we prepared the evidence packs and distributed them to PRS attendees. You can see in the middle the people we approached to participate in the peer review sessions, and then carrying out the actual peer review sessions from April to October 2024. Then following those sessions, we had the formation of a task and finish group to prepare the full draft. This group looked at accessibility and consistency in wording and terminology. Then once we had the final version of the full document, we held a 6-week wider stakeholder engagement where we opened up for feedback beyond those who were able to participate in the peer review sessions. Then finally, the endorsement phase, where we sought endorsement from the groups and individuals in that purple box before finally publishing on the 6th of August. So this diagram shows how the actual development of the guidelines took place. You can see each peer review session had a range of evidence and data that was used in the discussion and development of the new guidelines. This included the evidence reviews produced by Cancer Research UK and the literature reviews produced by Healthcare Improvement Scotland. And these evidence packs were sent out to attendees 1 month in advance. The box on the right-hand side there shows the criteria used throughout the process. So there was no change made without evidence. Symptoms or symptom combinations needed to have a PPV equal to or greater than 3% to be included. We needed to ensure there was concordance with other guidance, for example, the new QFIT consensus document. And all changes needed to have a strong clinical consensus behind them. We also used an EQIA throughout the development process and in each peer review session. And then following the peer review sessions, we had that wider stakeholder engagement, and these arrows indicate that it was a continuous loop of feedback as necessary. The engagement lasted 6 weeks from mid-December to the end of January 2025 and was open to all stakeholders. And then once that process was finished and we had addressed all comments, and new guidelines were finalized and published. So just a little bit of the EQIA. As part of this, at the end of each peer review session, each group was asked to consider if there was anything in the guidelines that could negatively impact any of the 9 protected characteristics. And we also included 2 additional characteristics of care experience and socioeconomic background, as these have been shown to impact engagement with health services. And this was done to avoid any unintended consequences of these groups. And then a little bit about positive predictive value. So the slide outlines what we mean by positive predictive value, or PPV. So in this setting, it refers to how many patients with a particular symptom are diagnosed with cancer. As indicated at the bottom of the slide there, we kept the PPV at 3% and set this early on in the review process. So this was based on evidence gathered by Healthcare Improvement Scotland and Cancer Research UK, and was agreed by our steering group. Lowering the PPV was seen to potentially result in diagnostic delays, and raising the PPV could potentially result in missed cancers. And then during the peer review sessions, we also looked at data for symptom and symptom combinations. So this graph is from Willie Hamilton's work, and it shows the PPVs for single symptoms at the top and symptom combinations for non-Hodgkin's lymphoma in patients over 60 years old. So to inform discussion in the peer review sessions, Healthcare Improvement Scotland was asked to provide evidence comparing the SRGs to international symptomatic evidence-based referral guidelines published since 2018. If any guidelines were found, HIS identified the symptoms and the clinical features included as predictive of cancer, and particularly highlighting any that differed from the old SRGs. And where possible, they identified the evidence used to support the inclusion of that symptom. One review was produced for each PRS, and like with Cancer Research UK, they presented the data themselves at each session. So likewise for Cancer Research UK, we asked them to conduct evidence reviews to inform the discussion at each peer review session. These evidence reviews consisted of peer-reviewed literature, symptom and combination risk, and survey insights and stakeholder conversations. Cancer Research UK also provided support in a variety of other ways, for example, generating evidence and insights via a survey of Scottish GPs about their opinions on the SRGs, particularly any barriers to use. And they also commissioned a qualitative piece of work investigating what impacts the use of guidelines UK-wide. So following the peer review sessions, and once we had the full draft of the guideline, we held the 6-week wider stakeholder engagement. During the course of this period, we received hundreds of comments. Each comment was considered, and some were taken back to the peer review groups for discussion as needed. And this was to ensure that the stakeholders who had shaped the guidelines were then able to feed in on more like complex or potentially contentious changes. Each accepted comment was then incorporated into the guideline, and updated drafts were then shared with stakeholders. The arrows indicate that this was a circular process, with drafts being updated and shared to ensure that the guidelines were backed by a strong clinical consensus. Individual feedback was provided for each comment, outlining why a comment was or was not taken on board, and this was done to be as transparent as possible. So following the wider stakeholder engagement, and when we had finalized the new guideline, we began the process of preparing for publication. The guidelines were published as a PDF on the Scottish Government website, and these screenshots just show what that version looks like. We also published as a new website version hosted by the Right Decision service. So you can see on the left there, each guideline has its own tile. And then the screenshot on the right shows what it looks like when you click into the guideline. In this case, it opens onto emergency referral criteria, followed by USC criteria, and then assessment. So user acceptance testing played a really important part in deciding what the design and format of the website would look like, particularly as the guidelines were being moved onto the Right Decision service from the previous website. And the website is the main method of use in clinical settings. During the testing, we were mainly focused on ensuring the guidelines were as easy to use as possible. And feedback was gathered on whether longer guidelines like urology should be split by cancer site. And this came through very strongly as yes. Despite that this would potentially bring an increased number of clicks to navigate. And we also looked at what each guideline should open onto, and this came very, very strongly as USC criteria, followed by assessment criteria underneath. So thank you very much, and I'll now pass over to Phil.
Sorry, Sarah, had a bit of trouble there getting it to take control. So thanks very much, Sarah. It was an excellent summary. I'm Phil Hodkinson. I'm a lung cancer clinician in Ayrshire, general physician as well, and I'm also the one of the co-clinical leads for earlier cancer diagnosis at CfSD. I've been given the challenge of summarising all the changes we made in the guidelines in a sort of 20-minute window for you today, and hopefully it'll spark some conversation about where we are. So just before we get started, I want to call out two resources that are available, which summarise the key changes. So the first is one that we wrote following all of that process Sarah described. You can access it through the Scottish Government website on Scottish Cancer Referrals. It's a 9-page PDF, just going through each section and explaining what we changed. But also there is a body map from Cancer Research UK that's been published that shows the new referral guidelines on one page mapped out to the body systems that it affects. And that's an excellent clinical resource for the new changes. We'd really urge that you start to look at these new resources now. They're both also available through the website, and kind of move away from the old guidelines. So the overview of the changes, they're kind of broadly in two sections. So clinical changes, things that we altered to guidelines to make them easier to use or more clear or have practical advice. And then the other sections, which are in RDS at the bottom in a little kind of 3-line box that you can go to, such as the introduction, the statistics, the referral process, etc. And I'm just going to run through each of these. I just want to call out the orange bar at the bottom, though, or the yellowy bar, because throughout the whole writing of this, what we tried to do was really employ the tenets of realistic medicine or value-based medicine, and also how we tackle deprivation. What do we do to tackle missingness, the inverse care law, so that when we're making referrals, we're thinking about patients, we're really focused down on these crucial elements. So clinical section, the first big change I think people will notice, and some people have said it's quite big now, this referral guideline, is that we've added something called clinical assessment, or assessment of suspected X cancer. And you can see it here at the bottom. It's branded throughout the RDS and also throughout the published guidelines in green, so you can see it. So when you click on one of the tiles, it takes you to this initial page, and just under the referral guidelines is how you assess. Purpose in this was to collate succinct guidance about those clinical features that are important for a cancer type, so that, you know, what are we looking for? Aid recognition in the clinic room, but also guide the next steps. What are the filter tests or assessments that you make with that symptom to then refine where you're referring, are you referring? This is an example of one. This is ovarian cancer. Not expecting you at all to write this, you know, to read through this just now. But I just wanted to highlight a couple of bits in yellow, because this is an example where we've said ovarian cancer, non-specific abdominal symptoms. What are we thinking of? And then These are the filter tests, the CA125, the ultrasound of the pelvis. You know that, but then really define who it is we should be thinking about with these vague symptoms, who should get these tests. And then above that, on that page, is who to refer based on those tests. In terms of symptom clarity, why were we changing that? Well, in the old guidelines, excellent guidelines, very good backbone for this work, but there were phrases in there like persistent, significant, generalized. We didn't really know what they were. We had a public partner who joined us, a lay person, and they called these out frequently. You know, what do you mean there by that, doctor? Who would you be communicating with that about that? So we developed phrases and specific durations, or defined exactly what we were talking about. And these are supposed to prevent delays to referral. So if you say something's persistent, is that 2 weeks, 6 weeks, a year? What do we mean? Make them more accurate and make them more widely usable for all clinical groups. So really get rid of the Dr. E's, as I call it. And we put a lot of the phrases in the glossary of terms to really emphasize what we're talking about here, something that we didn't have in the previous guideline. So this is an example. This is from breast cancer. So again, just to publicize RDS and its tile system, as you come in for breast cancer, you will see things like new unexplained axillary lump. We've taken away the word persistent or significant, made it 2 centimeters or more, persisting for 6 weeks or more, or increasing in size, to give some leeway around who you refer. We're not saying that you see somebody at day 1, you see them again at week 6, and then choose to refer them. If the patient feels it's that's okay, but it's looking for persistent things and how long. Serous sanguinous, so this is nipple discharge. What did that mean? Meant something to me, something different to somebody else, so we defined it. And these are throughout the guidelines. So as you're looking at them, they're supposed to aid you in making these referrals. Symptom clarity as well. So just to go back over that, persistent or non-resolving, clear time frame, different for each cancer. It's different for children and young people as well, what we meant by that. And we've written it out, we've been explicit. We also talked about things that are likely not to be cancer, because those are really important. We worry about things, and rightly so, but if you've got somebody with a feeling of something stuck in their throat, intermittent hoarseness, a soft tissue lesion that looks like a lipoma, we should be able to manage those and not refer them unless there are red flags. We also defined weight loss. This was throughout the old guideline, throughout the new guideline, and we made it unintentional, 5% or more of body weight, or a strong clinical suspicion, to allow primary care to be able to make that judgment. But really talking about it's not something we expect, it's more recent onset, and it's more significant. Define what that meant. We talk in this guideline now about a new referral criteria called the emergency route. Why on earth would we want to promote the emergency route? If you look at cancers, those that are diagnosed through an emergency route have a much poorer prognosis. This is your risk of dying. And these are the percentages of those cancers that we see, the big cancers that present through the emergency route. 70% brain cancer down to 14% of colon cancers at its best. However, we recognise that there are scenarios where same-day or emergency referral would expedite diagnosis. Now, some of these are things we'd refer anyway. I can't imagine anybody sitting on Strider in the clinic and send them away for a 2-week, clinic appointment. Superior vena cava obstructions, another. We really defined headache with new focal neurology, seizures, papilledema, some of the hematological malignancies, and obviously spinal cord compression. We've called these emergency same-day referral. They sit just above UCS referral, and the expectation is that you'll use your local system to get that person assessed today, tomorrow, in that urgent care setting, urgent clinic, or in the emergency department, if that's right. We've added new guidelines. So just to go through the different cancer types, so brain and cancer, brain and CNS cancers, we've added headache with cognitive impairment. Headache alone is poorly predictive. Add cognitive impairment, your PPV goes up above 5%. Breast cancer, new guidelines for under 30s. Remove breast nodularity because it was indiscriminate and poorly understood. Replaced it with a clear message about lumps. Mentioned the axillary lumps. Hematology, added some new criteria for odd blood tests, so lymphocytosis, possible myeloma, what you do with generalized or isolated lymphadenopathy. Head and neck cancer added an age, changed persistent pain in the throat to unilateral throat pain. It's more discriminate, more accurate. Colorectal aligned with the QFIT guidance, as Sarah said earlier. Lung and pleura, we've changed the criteria for when to do a chest x-ray. And what we've done is we split it up into whether you're a smoker or asbestos exposed from not, because there's a different threshold. Remove the age for hemoptysis. They should be referred. We can decide what to do with them. Added guidance on a normal chest x-ray. The previous SRG lacked that clarity around that. Sarcoma and bone, soft tissue masses, skins had a significant rewrite. And if anybody managed to get to last Tuesday, Lorna went through all of the new additions to skin. That's well worth looking at. But now we've tried to define what a skin cancer looks like and then said refer if it's suspicious for a skin cancer. Upper GI, there were some symptoms that were indiscriminate. When we looked at the vast info from the National Endoscopy Database, it became clear that these features here really were not predictive of cancer. There are other pathways being developed for them, and we should use those. And we added an age threshold for jaundice, because jaundice below 40 is highly unlikely to be pancreas cancer. Urology, we added specific advice on prostate antigen testing in older adults and in the context of a UTI, and we've aligned the new PSA thresholds with getting it right first time publication that is now in place in the UK. We've also added a non-specific symptoms section. There's a massive addition to the new SRG that allows you to take somebody who doesn't fit all those other sections and pick somewhere for them to go. And we know that cross-sectional imaging is that first test. So how do you get to that as quickly as possible? The new guidance should help. In cancer in children and young people, it was very much similar to a cancer type, but actually cancer in children and young people is a whole other guide. And when NG12 did theirs, they wrote a new piece to go with it, aligning to the this group called the CCLG, so this cancer in young people guidance, and we've aligned our guidance to that. We've also removed malignant spinal cord compression as a cancer type because there is excellent national guidance, but we link to it extensively throughout the guidance so that we're keeping one truth, because rewriting somebody else's guideline in ours results in contextual differences and inappropriate referrals and all of those things. So we've tried to keep to the one place, and it is an excellent guide, so look at it. What about the good practice points? Why did we change some of this? Well, there were old guidelines and now we needed to refresh. We had new guidelines, national guidelines, QFIT, IBD, the breast pathway work on MPP, dermatology on DermNet, and also on the RDS. Practical advice on how to assess some people with symptoms. So we just developed again some of that guidance on how to take somebody who may not have cancer, but how you might manage them into the system in the appropriate way. And the whole purpose of this is this vigilance versus referral investigation. How do we pick it up, make the right referral? How do we hold on to some of it, investigate a bit further? And there's a comment in the Q&A we need to pick up later about some of the news from England today. So the good practice points, this is just an example, something about neck lumps, what you're kind of looking for or not looking for, and also something in here about the changing patterns of disease. Head and neck cancer is altered. It's not just in 60-year-old male smokers anymore. There's a whole differing demographic. So to call these things out where we could. These are some of the links that we built in. So throughout each one, we built in charity websites that we agreed were excellent additional clinical information. Better Safe Than Tumour is a particularly good resource that describes brain tumour presentation at differing ages. The national guidelines, such as the dysphagia pathway, QFIT, headache, how those fit in with our guidance, and we fed back to the authors of these about our guidance to make sure our guidance fit in with them. Some expert guidance that may not be published on CfSD, although will hopefully be coming, are things like postmenopausal bleeding, the prostate-specific antigen testing guidance summary for GPs in line with the prostate cancer risk management pathway. We've also included risk calculators, not because we want these employed in primary care. We know that they don't perform as well in primary care versus secondary care, but because the information that secondary care uses to vet, and Lorna said everybody's doing the same job, there are key bits of information in there that if we can include in referrals, we can actually improve the use of these and therefore improve the optimization of the diagnostic pathways. That doesn't mean to say don't refer somebody, it's put that information down if you can. And there are some Sky Gateway referral templates that have got these bits of information already built in. And the national services, we've linked to regional genetics centres. There's, I can't remember, there's 3 or 4, but that whole information needed refreshed. So what about the other bits, the stats, the referral process, that terminology? So the statistics, I mean, you need to refresh the statistics anyway. You've got to have your peer review sessions with the most up-to-date statistical information, so you're clear about the changing demographics of cancer, and you know where we are in terms of incidence and differences in age and sex. Also to understand the risks of cancer so that we can put our patient in the context of their risk for cancer, and that enables us to make the most appropriate referrals. And again, demographics, frequencies of presentations, and the routes to diagnosis, and understand where there are delays. There are delays in some cancer pathways because of delays to diagnostics, and some because they present in a vague way, and therefore they're difficult to be vigilant for and not over-investigate. We just tried to flag that. It's by no means indicating it's somebody's work to manage that delay, but if we're aware of them, then we can do our best to move forward. So this is just an example of how we use some of the statistics. So this is going to make everybody on the call wince a bit, talking about an average GP practice. This is just in terms of numbers, not demographics. There is no such thing I know as an average GP practice. But if you take the average number, you would expect to see per year, per average practice, about 6 cases of lung, bronchus, trachea cancer, down to about 1 pancreas cancer. So it just gives a context to the work. And this is the 10 most frequently diagnosed cancers according to Public Health Scotland data. This is an example of breast cancer, just how we've called out in the guidance in the in RDS and in the publication some of the risk factors you want to look for, some of the demographic information, and the stark difference between male and female breast cancer, so that we're aware of that. In terms of the referral process, and this was quite a big change, and I wanted to when we did this, a team wanted to reflect how we could support referrers to do that right thing. So we've added new information to the section that was on the old website to really highlight the role of GP gut feeling, what it means, how that's useful in terms of interpreting risk of demographics, risk of symptoms, and actually make those referrals. I mean, as a secondary care clinician, I'd like to see that actually called out in referrals. I'm worried this is cancer. It's my gut feeling this is cancer. I'd take that because I think that is very, very helpful. We've called out the non-specific symptoms, including weight loss, and talked about defining it. We've expanded the guidance on thrombocytosis because that was a common referral reason, certainly into RCDSs. We've called it metastatic cancer. We got quite a lot of feedback from the charity groups about that as a group, and also a difficult group to know who to refer to. So we brought, when they represent again, so we called that back again, and the role of tumour markers. And throughout all of this, we've linked to realistic medicine, rehabilitation and health promotion. So even if you don't refer somebody who's having cancer, they've probably got a risk for cancer. So what can we do as a brief intervention to try and help manage that? And lastly, as I said, missingness and the inverse care law. How do we take our people who need it the most and help them get into the system and stick in the system and navigate the system? And so we've created external links to that. So if you look at this, this is what's built into the guideline now. This is the brand concept. So will it benefit? Are there any risks? What are the alternatives? And if I did nothing, what would happen? And you know, if I were a patient, would I consider doing nothing? Which I think is a crucial thing to think about. And we've linked to things like the ECOG performance status to help describe what somebody is like at home and clinical frailty. And lastly, as I said, there's links to how we might potentially intervene in that deprivation demographic gap. So I'm going to hand back to Lorna now, and then Lorna can talk about the next stages, and that should give us a sort of 15-minute, 20-minute window to do some Q&A, hopefully at the end. So thank you very much.
Yeah, thanks, Phil, for going through all of that so well. I'm now going to give an overview of the next steps. So there's a 6-month window for implementation for boards to make all the changes needed to facilitate the use of the updated guidelines. So the changes that are needed may include updating any Sky Gateway referral templates and test request pathways in ICE and order comps, if you have them in your board. Also enabling interspecialty referrals where possible, whether on Sky Gateway or through other avenues. Many boards will have their own local referral pathway guidance, for example, on the Right Decision service or on Ref Help. And these will all need to be updated to make them consistent with the new referral guidelines. And we do know that many boards are already in the process of doing that. Any old hard copies of the previous quick reference guide or the cancer body poster will need to be removed and recycled. And the old SRG app should be deleted from your phones. If you do already have the old app on your phone, if you refresh it, you will find it takes you to the new guidelines on the Right Decision service, but it's better if you can to delete the old app and download the Right Decisions app instead. So this shows you what the old hard copy of the quick reference guide and the body poster and the app look like. And you'll see they have a different colorway from the new guidelines and app. So as you can see, the new guidelines have a different color scheme where they've got purple on that front page instead of blue. There are no hard copies this time. And the main reason for that was really the difficulty of keeping them updated. The full guidelines, as you've already heard, can be found on the Scottish Government website, where you can also find the summary of key changes document. And the cancer body poster gives a summary of the guidelines, and that's also been updated. And you can order hard copies of this free from the Cancer Research UK website. The updated guidelines are now hosted on the Right Decision service, which many of you will be familiar with. There's an app if you search for Right Decisions, as well as a website. And once you open the website, search for Cancer Referral Guidelines. Now, there's something seems to be missing from this slide, which did have an image of what you see when you open the guidelines on the website. But Phil and Sarah have already shown you that really. So when you click on one of the tiles on either the website or the app, as already been said, you'll find it opens up the assessment and urgent suspicion of cancer sections for that tumour type. Now, as it's already been said, but I really want to stress it's really important that you look at both of these in conjunction as they're complementary to each other, as Phil described in the, for example, in the skin one, the assessment section gives you a lot more detail as to what to look for in suspicious lesions. You can open up good practice points and background tabs if you want more information, and the good practice points in particular contain a lot of practical advice, including links to the other non-cancer national pathways where relevant. Oh, it comes up. See there, it's much more sophisticated than I thought it was going to be. So there you go, there are the images. Education for all around the updated guidelines is really important. Gateway C is a free NHS Scotland commissioned and National Education for Scotland supported educational resource, which has learning modules on different cancer types. These have all been updated to be consistent with the new referral guidelines. If you'd like to, you can scan on this QR code you see here to register. Just give you a minute in case anybody wants to scan that. So on the Gateway C website, they've also produced short videos, or they can be listened to in audio version. And these have been done by all the Health Board GP cancer leads and are on the key changes for each tumour-specific section. If you're interested in looking at those, if you scan that QR code that's on that slide, that'll take you directly to the videos. They're being uploaded a few at a time, so you won't see all 14 at the moment, but you will over the next few weeks. Next year, National Education for Scotland are going to be providing a cancer education programme for GP specialist trainees. There'll be a national webinar for the GPST1s, short 1 hour webinars during the hospital placements in ST1 and ST2, and for the GPST3s, in-person facilitated sessions, which are going to be more focused on the complex and non-specific symptom presentations. Cancer Research UK also provides a lot of Scotland-specific educational resources on their website, including the cancer body poster, as already mentioned. On that page on the left of the slide, you'll see down at the bottom, it is the link to order the posters if you'd like to have them. So the Centre for Sustainable Delivery intend to measure the impact of the guidelines where they can, using a variety of metrics, including referral trends, access to analytics for the website and app, and primary care surveys. Measurement at a local level is also important, and the Framework for Effective Cancer Management asks that health boards should consider measurement of referrals and regraded referrals, which may show some opportunities for improvement. Any new research findings that might affect the guidelines should be highlighted to the SRG team. There's the email address there, as well as any impact of the guidance at a local level. So that's all I was going to say, and I'm now going to hand over to Rory Mackenzie, who will facilitate the Q&A section.
Yeah, hello everyone, and thanks very much, Lorna, and thanks to Phil and Sarah beforehand. I'm Rory Mackenzie. I'm actually a consultant critical care, but I work as interim deputy national clinical director at CfSD, and I chaired the steering group overseeing the review of the SRGs. So people have been putting questions in the Q&A, so I'm very grateful for that. Some have been getting answered as I go along, but I think if I can go through them and continue to add questions if you want to do that. So the first question, which I think is a really good one, is around how do we work together to spread the implementation of these guidelines? And that was Chris Proven that had posted that. I don't know if anyone wants to cover that. I know, for example, Chris, that we've made initial contact with RCGP to see if we can just collaborate on the dissemination of some of this. So that's one particular way. Anyone else want to comment on that?
I can come in there if you'd like, Rory. I mean, I think I've talked a little bit about what we can do. I mean, I think it's fantastic that we're now going to have that more standardised education with for GP trainees. Douglas Rigg, who's on the call, has been very instrumental in working with NES on that, along with the rest of us in the Scottish Primary Care Cancer Group. So I think that's one thing. But I think in general, it's just raising awareness. So those of you on the call today can do a lot to help with the implementation, just making sure that everybody within your practice or within secondary care know about the new guidelines. As I said, it's really important that we're all working to the same guidelines. And also, I mean, using Gateway C, which is a fantastic resource, which has lots of education plus the videos. I don't know, Phil, if you want to add anything else.
I'll let Stuart come in.
Yeah, I agree with everything Lorna said. I think there's probably two levels of kind of making sure they're implemented. One is kind of at the interface group level at boards. So obviously there's a big push now, and working with RCGP, trying to ensure that every board has a functioning primary care, secondary care interface group or board, and this is a really important type of guideline that should sit there in terms of making sure the routes for GPs to access specific referral pathways are available, and as Laura described, the Sky Gateway changes, etc., are put in place. And then I think for kind of making sure there's awareness amongst the clinical community of GP referrers, things like bringing it up with your GP cluster. So it might be the sort of topic that GP clusters want to cover as part of their quality improvement work or review together, thinking about GP forums and whether it's brought to kind of GP education sessions locally as well as nationally. So I think there's lots of different ways that we can use to try and make sure this gets out to people. But I think any ideas would be welcome. Anyone wants to get in touch with us at the end of the meeting, we'll be happy to take any feedback or suggestions.
Yeah, no, thanks. And it's a really important thing, isn't it, about how we get these out there and socialised and used, as we've got 6 months to work on that. So the next question, although it's directed at the EQIA, it's really around about geographic isolation, island and rural qualify as a factor for the EQIA, but perhaps if we could comment on how we ensured that rural and island communities were represented within the review process. Lorna or Phil, maybe? Or Sarah?
Yeah, I don't mind coming in on that just now. So I guess what we've got is the SRG, which is a description of the type of patients we ought to be thinking about cancer in. Some of the tests that we feel we ought to do, and as we work through it, there were clearly some differences in what was available to primary care to use as a test. And I think that bit, the testing bit, we've tried to pick up when we've done optimum pathway work, so that diagnostic workup. How do we create that standard approach? And then you've got referral after that. I would hope that when you look at the SRG, you don't see something that's different depending upon where the person is. The EQIA work was intended to cover the 9 protected characteristics because that was right. We were making changes to ages or talking about differences in cancer rates based on sex, and also wanted to include work about gender reassignment, etc., so that we were clear about so we didn't disadvantage somebody. I think the next bit of work for all of us is to try and get those standardized access to those routes. And some of that work is inherent in the rapid cancer diagnostic services that we've been trying to roll out, because there are patients who because of the volume of the work in an area, you'd be better using that system, or in terms of the vagueness of presentation or some of those filter type tests that you want, that would be a good way of doing it. And we're not there yet with the population coverage for that kind of service. So I think we started with patients and symptoms. It wasn't intended to start with geography, I think, is really what I want to say. So it's supposed to be neutralized out by how patients present.
Yeah, no, thanks, Phil. That's great. So, somewhat topical, Jess's Law was in the news this morning. there's been a question, will Scotland follow this? I'm not sure we can say for sure on that, but Stuart, did you want to comment on how these guidelines might assist, I suppose, in avoiding that sort of issue in Scotland?
I'm happy to. I think probably Lorna, I'll hand over to Lorna to maybe answer that, but I've put a link to the NHS England site which describes kind of what it is and what the ask is, and that in many ways it is kind of good practice amongst GPs anyway. But Lorna.
Yeah, thanks, Stuart. I was just going to say that actually we're ahead of them, because in the old guidelines, we already had that included in the children and young people section, that if there's basically like a 3 strikes and you're out, that you refer on. And we have included that again in the new guidance. Phil, did you want to add to that?
Yeah, it was just to say as well that actually the principle of minimizing repeat presentations before you refer or think of that test is built throughout a lot of the guidance. And if you look at lung cancer, for example, we've said 2 exacerbations, 2 chest infections. So you should think about the chest X-ray, and that's how we'll pick up the cancers. So I think, yeah, we can't comment on whether Scotland will adopt it, as you know, but for me, and exactly what Stuart has said, I think that's good practice. I think it's not unreasonable, and it's absolutely explicit in the children and young people's guidance.
Yeah, no, thanks for that. And that was one of the questions, and that's been signposted in the chat, that there is a section on children and young people's cancer. Interesting question around about, is there any evidence to support direct access or self-referral for people with certain symptoms or signs without them having to go through general practice? So Douglas Rugg has commented on the breast lump work that's going on. Don't know if Phil, is there any other things in the pipeline, or any of the team aware?
No, I mean, we're very keen to see the outcome of the work that was supported in Forth Valley with the breast cancer self-referral pathway. I think breast cancer's quite a bit different than some of the cancer types, in that it has a very narrow symptom signature. And lumps are worrying and can not infrequently be cancer. So I think that's the right pathway for that. I think you would struggle to make a self-referral pathway for vague abdominal symptoms or something like that. So we've got to listen to this work, see where it fits in. Is there a role for other triage systems that might allow us to manage the concern to the right investigations? I think there probably is still more to be made out of RCDS. So yeah, it's a space that in CfSD we are aware of and we are watching, and also the role of other practitioners who might not usually refer into a UCS. So how do we do some more work with pharmacy that they might be able to make those referrals? How we generate those referral pathways. So yeah, I mean, I think it's a really important bit of work, but when it's lacking absolute evidence at the moment for other cancer types beyond breast.
No, thanks, and it'll be interesting to see the outcomes of that approach. Their question's probably worth covering off. Why is the app being discontinued? I presume we mean the previous link through NSS. It was very helpful. There have been some comments on that, but is it worth describing the RDS approach? And I think we've demonstrated the accessibility aspects of that, and the user acceptance testing as well. Anything to add to
that? So Rory, we approached again the hosts of the previous website. We approached RDS. We looked at a variety of options. I think RDS came out on top partly because of its usability, its support, the speed of turnaround. They're wanting to work with us to make it better, and the ability to build better as you go as well. And the app linked from RDS was very good, and we put a link into Google Play. We can get it in Apple. I've got it on my phone now, and it is an excellent resource. And the way the app looks is the way the website looks, but in an app form, as opposed to being a completely standalone. And as we alter RDS, the app alters, and therefore we end up with the right information in two places at the same time, if you see what I mean. That was a really important element of it. So that was why we've gone with that new app, I think.
Yeah, that's great. Hopefully people have picked up information about the Cruck infographic poster is sold out, but there is another run being developed. Somebody's mentioned that in the chat. So that's good that people are recognising that as a really valuable resource. It is fantastic, actually. At our in-person event last week, with the number on the table, they were all picked up very quickly. So we'll try and pick up on that and try and communicate out when they're coming. Also, somebody's asked, could we share a list of all the links mentioned on the webinars? You're absolutely right. It's difficult to take notes of them as they're shown only for a few seconds. So we shall take it upon ourselves to share them afterwards. So a question here, does this new guideline increase pressure on emergency admission or clinics or towards the on-call team? I suppose it's too early to say, but I don't know if it would be worth commenting on how that was considered with the work at the PRGs. Phil.
Yeah, so you can't actually work that out yet, as Rory said. The intention was to get the right person to the right place as quickly as possible. So if you look at emergency referrals, I did a piece of work in lung cancer in Ayrshire, just as an example. 40% of our referrals were diagnoses came from the emergency route. So they were admitted to hospital with symptoms of advanced lung cancer and did very badly. Actually, very few of them were on a primary care pathway referral into clinic. The people themselves had held on to symptoms, or the system had not supported them to get to somewhere with their symptoms, and so had not come in. And when they came in, they're much more frequently, threefold more likely to have stage 4 lung cancer. So the idea here is that if we can get the right people referred, we can get people to come. So there's detect cancer early work, isn't there? Be the early bird. We can get people to come. We can filter out who we refer. We refer the right people on outpatient pathways, and then we pick up that bit above it about capacity to do the work. So the optimum pathway, how do we standardize that, reduce variability? We will have less emergency diagnoses. However, there are some things need to be diagnosed by an emergency because they are an emergency. And so the two things are going to play off each other. However, if we could recognize, if we had a system for recognizing brain cancer a bit earlier, we will reduce the number of emergency referrals because we'll be able to pick people up before they have a seizure as their presenting feature. That piece of work still needs to play out, and we need to work out what the tools are to do that. So the SRG is a component of the work to get us to the right place, right time, I think. Long-winded answer, sorry.
Yeah, thanks, Phil. And probably related to the next question, but has there been any thought on linking up the referral pathways with related national pathways, e.g. the optimal cancer diagnostic pathways and the Scottish Clinical Network's clinical management pathways?
You want me to come in on that one as well, Rory?
Yeah, that'd be good.
Yeah, so we spend our time networking and linking between. The SRGs were not written in isolation from the optimum cancer diagnostic pathways. Lung cancer came first. We wrote that based on the old SRG. Well, we've looked at it again with the same people who developed that pathway in the room. Colorectal cancer that's just about to go live or has gone live was done very, very closely with the QFIT consensus, the national guidance on that, but also with the view to the SRG and how to refer somebody, how to get somebody in. So we link those. the clinical management pathways then link at the end of the optimum pathway. So what we develop through the optimum pathway should link into the clinical management pathway. And we're just in the process of working on the scoping. You remember Sarah's document, that big red block at the beginning, the scoping for prostate cancer. There is a CMP for prostate cancer. We've got an SRG for prostate cancer. How do we join them together with the optimal pathway? So it is all linked. It just may not appear to be externally all linked, but if you've got one you want to ask about, just get in touch with us and we can talk through where we are, and if you think there's any gaps, it's good to know so we can smooth those gaps.
Yeah, no, great, thanks Phil for taking that. So next question is, if GPs refer appropriately according to the guidelines, the hospital system needs to also respond appropriately to the referrals. Can these guidelines and the publicity associated do anything to improve current waiting lists, e.g. for postmenstrual bleeding?
So, yeah, maybe Lorna wants to come in a bit bored of hearing my voice, I guess.
Lorna?
I was just going to say, going back to what I'd said in my presentation, is that, I mean, these guidelines are both for primary and secondary care and for allied health professionals and other colleagues, anybody who might be seeing someone who might have symptoms of cancer, or on the other side of it, who might be triaging it. So we would hope, if everybody's working from the same guidelines, that that will improve things. But I'll let Phil talk a little bit more about the more technical side.
Thanks, Lorna. Yeah, so secondary care responding is intrinsically linked to capacity, and what we need to do as we do this work is also continue to work at using the capacity we have appropriately, but also building some capacity and building it with the best systems so that we can join it up across Scotland, and that we don't have a health board that has one breast consultant or one breast radiologist. We have Scotland that has 15, and we can do that work and we can share it as an example. There are some real choke points, aren't there? So prostate cancer operating, we talked about postmenopausal bleeding, we know about skin cancer weights. So these are areas that we've got to continue to work on. The other side of the house to the earlier cancer diagnosis, cancer performance that CfSD sit in, and I join. So there's no kind of mystery about why those two things are joined up, because they need to be joined up. But if we don't write the guidelines properly to get the referrals in, we won't get the right people on the right pathway, and therefore we'll be diagnosing cancer in our routine waiting list, which is not right. Equally, though, secondary care needs to carry out some triage, some expert assessment of what's been sent in, and try and pick the right place for somebody to go, just as primary care has to pick the right people to refer. So it's all a joined up thing. I'm doing some work in my own board, not because of my role, but because I was asked to by the medical director. So I think medical directors are very keen on this, to do some work around those pathways, how we pick people up from the referral and get them in, but also how we use the SRG to drive the right people into those pathways.
Okay, great. And I think it's just time for one last question, and it's around about that wider group of referrers. Will there be any opportunity to share updates with advanced practitioners in primary care, as there are many health and social care partnership employed AMPs and APs who might miss updates going to GP practices? Referencing a great session with the Advanced Practice Academy in the past. Lorna.
Yeah, as I said, really in answer to the last question as well. I mean, these guidelines are not just for GPs. They're for anybody who's within primary care. They're for other colleagues. They're for pharmacists. They're for dentists. They're for secondary care. And we'd hope that they would be shared as widely as possible amongst all these colleagues. As far as education's concerned, Gateway C is not just open to GPs. I mean, advanced nurse practitioners can sign up, other clinicians can sign up, and I would really recommend that you have a look at that, because you can do them in your own time. You can do bits of a module at a time if you want. Each module usually takes about an hour, but you can do a bit at a time, and there are the videos as well. So share the educational resources as widely as possible is what I would say.
Yeah, Yeah, so any feedback on how we make sure the reach is as broad and deep as possible, then please let us know. So that's 1301. Thanks very much, everyone, for posting their questions. Stuart, do you just want to?
Yeah, thanks, Rory. Really, just to end, to thank all of the speakers today for a fantastic session. Thank you to colleagues for making the time to attend. I think it's the highest attendance we've had. Obviously, the session is recorded and you can watch that back. There's the link there to the feedback form, and that will be really helpful to help tweak and maximise the benefit of any future sessions. So if you could follow the link or use the QR code, that would be fantastic. There's also a link there to all of the previous webinars and recordings of those. This is the 6th, as we say, so there's a number on there that are available to look back on. And then finally, a plug for our next session, which is on Thursday, the 6th of November. That's 5:30 to 6:30, and that will be the dermatology pathways and resources. So again, thank you very much. And as I say, we appreciate your time in attending and speakers for coming along.
Thanks, everyone.